everybody. Good afternoon, and thank you for joining us at Superior Health Quality Alliance Nursing Home Leadership Roundtable, where we are going to continue our series about turning your deficiencies into efficiencies. And today our topic is slightly different. It'll be enhanced barrier precautions. My name is Constance Tetrov, and I am a quality improvement advisor with Superior Health Quality Alliance, and I am accompanied by a few of my colleagues. Miss Margaret and Miss Jessica are here today helping us in our roundtable. It will be slightly different roundtable where not only will I be facilitating, I will also be presenting our topic. We host these 1-hour sessions on the second and the fourth Wednesday of the month. The first half is a didactic presentation. Then the remaining time will be for questions and answers. The presentation link will be dropped into the chat momentarily. And please use the chat box to share any comments, questions, and even resources during the presentation. Besides learning from our speakers, we learn from each other and our peers. Towards the end of today's event, we will also post an evaluation link in the chat that will only take you 1 to 2 minutes to complete. We use your evaluations to help us give you a better experience. We'll go ahead and get started. Give me 2 seconds here. So you can go to the next slide. Our objectives for the first part, go ahead and go to the next one too, is to review the 24-25 COVID-19 recommendations, discuss some best practices in achieving increased vaccination acceptance, and explore some practical tips for increasing vaccine compliance, as well as share any vaccine resources that we have. Next slide. So 24-25, everyone aged 6 months and older should be able to get 1 COVID-19 vaccination. People who have recently had COVID-19 infection can delay COVID-19 vaccination by 3 months. People who have received the 23-24 COVID-19 vaccination can delay vaccination by 2 months before receiving the 24-25 COVID-19 vaccine. For most people aged 65 years and older, an additional COVID-19 vaccine dose is not currently recommended unless you are moderately or severely immunocompromised. Next slide. The mRNA vaccines, they target the KP2 strain. Pfizer and Moderna are the 2 brand names for that one. We do have a protein-based vaccine, Novavax. This one targets the JN1 variant. People who have had particularly adverse response to previous mRNA vaccines might consider the Novavax vaccine as an alternative, as it's protein-based, and those kinds of vaccines don't generally induce as strong of a side effect. If you're tired of COVID vaccines and that's what you're hearing from your staff, please think of some of our resources, use some of our resources to assist you with talking to staff about it. One hint is not to call it a booster. This is new information for their body, so it kind of decreases that, that thought process. On this slide, National Healthcare Safety Safety Network documentation periods. We're in the Q4, effective September 30th, 2024. An individual will be considered up to date if they've received a single dose of the 24-25 updated COVID-19 vaccine. Under these new recommendations, most individuals will not be considered up to date until they've received that dose of 24-25 updated vaccine. Facilities should report 0 individuals as up to date until this vaccine is administered. Next slide. Some vaccine compliance best practices and practical tips. Using a multi-vaccine consent form, that should be the norm. Obtaining that during admission. Remind families, residents when clinic is at and that they've already signed a consent form. You can always script what you're going to say before reaching out to everyone with data to support. Everyone should be sending the same message if you're using other people to assist with messaging. If you have billing challenges, you can consider roster billing. Implementing cultures of vaccinations and setting a vision of what your vaccination mission is for your facility is important. Using knowledge and encouraging your staff efforts to get vaccinated is really important. It also is important to help build trust, develop some standard processes and guidance, and then use data to guide your conversations. Go ahead, next slide. Here are several different resources that you can use. The Vivint Health and the Mobile vaccination clinics go until October 31st, and then those programs will be ending. Just as a reminder, so if those programs you're trying to use them after the 31st, they will not be available. Next slide. And we'll get started with enhanced barrier precautions. Yay! Okay, so this training or education is based off our annual infection prevention and control training that we're doing in facilities in person as well as on demand. So you're going to get the same experience that they would have. Welcome. I am glad to be presenting this topic. It's a topic of interest, so we're very excited. This presentation will also be linked in, I think it'll be on the YouTube channel once with this recording as well, if you want to go back and watch it. Next slide. So our objectives for this portion of the education is to describe the purposes of enhanced barrier precautions, EBP, and list the necessary personal protective equipment, PPE, that is required, explain why using gowns, gloves during high contact resident care activities is essential for preventing the spread of multi-drug resistant organisms, and identify specific key moments of application of EBP to task specific resident care activities. So we really want to delve into the purpose of EBP and why it's crucial part of our healthcare practices. It goes over a lot of the information of what you'll need to implement the program, and we'll talk about the key moments of how you can use this. Next slide. So what is an MDRO? MDROs are bacteria that have developed resistance to multiple antibiotics treating the infection. They're associated with longer hospital stays, higher cost, increased mortality rates. Patients infected with MDROs often require much more intensive treatment and longer recovery periods, which strain our healthcare resources. So they're a threat to our residents. And they pose a significant challenge in healthcare. So they're associated with super long hospital stays, higher costs, and increased mortality. This is because the antibiotics that would usually be effective are no longer able to combat these resistant bacteria. Patients with them, or residents with them, often are very sick and have a hard time recovering. Go ahead and go to the next slide. So antibiotic resistant and treatment options, MDROs are resistant to multiple classes of antibiotics, making treatment very challenging. Their limited effective antimicrobial options lead to the suboptimal outcomes for our patients. The emergence of MDROs reduces the arsenal of available antibiotics, affecting patient care and complicating treatment decisions. It is also, when we face these challenges, we need other alternative interventions. So that is where enhanced barrier precautions come. They serve as our first line of defense against the spread of resistant organisms. Next slide. This is a table that talks about infection versus colonization. It's important to know and understand the difference between colonization. Colonization is, I have this bug in my body, I have this presence of microorganisms, or germs as I call them, that don't cause me disease, but they still could. They're present, they can grow, they can take effect if you're immunocompromised and cause infection. But right now, currently, I'm not having any symptoms, or I have an immune response. I'm not having an immune response. It can be harmless bacteria in your nasal passages. You can be an asymptomatic carrier, and it can come obviously from contaminated surfaces or from healthcare workers and other residents passing it along. Infection is actually harming me. Microorganisms or germs invade the host tissue, that's the person that has it, and they cause a disease. They cause a problem in the person. They replicate within the host tissue, causing tissue damage, immune responses, and clinical symptoms. This is the person that might have a fever. They appear ill. Bacterial pneumonia, viral infections, fungal infections, these are all infections that can cause symptoms in a person. But colonization is over here, and it's lying in wait, I like to say. And infection is, oh, I'm actively having symptoms. Next slide, please. The rationale for use of EBP measures and additional interventions, large numbers of residents ranging from 53 to 71% became colonized with MDROs after being admitted to a nursing home. So we have a lack of awareness among healthcare workers, and focusing only on residents with active infection fails to address the continued transmission. So we did focus on doing transmission-based precautions, but it didn't lead to enough of a reduction in that. We're still at that 53 to 71%. And in fact, it grew. MDRO transmission occurs during high contact care activities. The studies have found out that they are occurring more with those high contact activities. And there's a little icon here that says more than 50% of our nursing home residents carry an MDRO currently. Go ahead to the next slide. So it becomes a national priority for prevention and control. So they're looking for us to monitor, prevent, and control MDROs as a priority at a national level. Healthcare facilities, along with federal, state, and local agencies, share responsibility in addressing this issue. We have to involve all of them because there's a wide large problem. There's evidence that traditional transmission-based precautions, like I said, in skilled nursing are not implementable for most residents to prevent the MDRO transmission. EBPs protect high-risk residents during high care activities while also ensuring that home-like environment. So the balance between the home-like environment and protecting residents is really important. And so we need to look at our approach to preventing and controlling MDROs. Next slide. So what are EBP? What are EBPs? EBPs focus on targeted use of personal protective equipment, gowns and gloves for high contact resident care activities when contact precautions do not otherwise apply with nursing home residents. Whew, that's a big one. So people with wounds, people with indwelling medical devices, regardless of colonization status, they will be EBP people. So they will have enhanced barrier precautions to protect them from getting it from a healthcare worker or another resident and passing it on through the nursing home. In addition to that, infection or colonization with an MDRO, whether you're infected or you're colonized, you will also have EBP. So if you recall, we discussed MDROs and that multi-drug resistant organism, residents who are infected with or colonized with MDROs are at significant risk, but also are at risk of passing it on. So people with wounds are at a higher risk because they have an opening. It's a highway to infection. In addition to that, anybody with an invasive device has an automatic highway. That's an interstate to an infection, right? Because they have an outside foreign thing in their body that gives you a literal interstate, right? Next slide. So that makes them higher risk. So what is a high contact care activity? So dressing, bathing, showering, changing linens, changing briefs, or assisting with toileting, device care with catheter, IV, PICC lines, CVCs, feeding tubes, trachs, vents, any device care, right? And during therapy is an additional physical, occupational, or any speech language therapy often require close contact between therapists and the patient, increasing the risk of transmission of infectious agents. Changing briefs, these activities involve direct contact with bodily fluids, significantly increasing the risk of transmission. Device care, obviously, you're providing either a clean technique or a sterile technique. My words failed me for a moment there. Changing linens, you're in the environment where the risk is higher. So when you're changing clothes, doing all of those things, go ahead to the next slide. They all contribute to a higher risk especially when bundled with that AM and PM care. So when else could you use EBPs? When else would you use EBP? I apologize. Providing hygiene, transferring any wound care of any kinds. And this just kind of gives you a directive of you're going to perform hygiene. You're going to wear a gown if you're doing those bundled care activities and in those high risk activities. And then you're going to wear gloves and you're going to dispose of it when you leave and wash your hands. So next slide. So this is the interesting part. Why EBP? So EBP was chosen based on observations of care in SNFs and long-term care facilities that evaluated the potential for antibiotic resistance bacteria to contaminate hands and clothing of healthcare workers. These activities were shown to pose the greatest risk to our residents. These activities identify posing the greatest risk to both residents and healthcare workers in terms of acquiring an MDRO, or a multi-drug resistant organism. Furthermore, despite our best efforts, we've identified continued gaps in infection prevention and control practices, and these gaps necessitated additional interventions to reduce transmission. So the adoption of EBP is a strategic response to the observed changes in skilled nursing facilities and long-term care facilities, aiming to protect both residents and healthcare workers from the continued risk of MDROs and improve overall IPC practices. Go ahead to the next slide. So previously, EBP recommendations from the CDC. So this is in 2019, the CDC released recommended EBP best practices, which many facilities adopted. These policies may, if you implemented back in 2019 and you're working on this implementation program now, they may need to be tweaked. You need to review them and make sure that they meet all of the standards, because the standards were slightly different in 2019 versus where we're required to implement them. They focused mostly on residents with MDROs, or if the facility was having an MDRO outbreak. Now that is a part of it, but it's not the only part of it. Next slide. So the Centers for Medicare and Medicaid Services released memo QSO 24-08 nursing homes, and they required facilities to align with nationally accepted standards. Use of EBP for residents with chronic wounds and indwelling medical devices. This is where it starts to be a little different. We didn't do that necessarily before to implement them. And a key point of using it is that they're at risk, right? So we need to give some protection. Not only do we need to handle the colonization and the infection of an MDRO, but we also need to protect the other people that have a much higher risk. So using EBP for residents with chronic wounds and indwelling medical devices made the most sense based on what you'll find out later. Surveyors will also be evaluating the use of EBP when reviewing sampled residents for whom EBP are indicated, and focus their evaluation of EBP use as it relates to the CDC's targeted MDROs. They are already doing that. There is increased what's the word? There's more citations being issued for EBP now. So they are asking questions. So EBP is incorporated into F880 and a part of that survey process. And it is a common citation for throughout the country right now. Lastly, the memo states that EBP, not only is it incorporated, but it highlighted the importance of CMS placing on the use of EBP in our facilities. It underscored the importance of aligning with nationally accepted standards and the critical role of EBP in ensuring health and safety of our residents and our staff. Next slide, please. So in this recommendation, it expanded the recommendation. It is in addition to our regular, already occurring IPC practices, our standard precautions that apply to every single person that we ever come in contact with, and transmission-based precautions. Studies have shown that there is a need for additional IPC measures to prevent that spread of MDROs. We needed a broader approach to reduce transmission for MDROs to protect residents and healthcare workers, and they have shown implementing are an effective way to reduce the transmission and spread when used with evidence-based infection prevention and control measures. Next slide. So there's a comparison of the precautions. I put together a chart with this, and it goes through standard precautions. They're everybody. It's all residents, all staff, everybody. Anytime I see blood, anytime I see bodily fluids, I'm treating everybody the exact same. I assume everybody has every single possible disease. Not a hypochondriac. Standard precautions. When you're going to use it with blood, bodily fluids, mucous membranes, non-intact skin, potentially contaminated environment services, and equipment. If you're at risk, use is required. Risk assessment determines what PPE you'll need depending on your anticipated exposure: gloves, gown, face mask, eye protection. You change PPE before caring for another resident. There are no room restrictions required with standard precautions, right? We're going to use them on everybody, so we wouldn't have a room thing. Next slide. So EBP at a glance. This kind of gives you a who, what, when, where, and whether room restriction is required. So EBP is residents with infection MDRO, colonization of MDRO when contact precautions do not otherwise apply. This is regardless of whether they have an MDRO, they're colonized or infected. Doesn't matter. And then in addition, chronic wounds and indwelling devices. Central lines, urinary catheters, indwelling catheters, feeding tubes, trachs, vents. When I talk about this slide, I also talk about the fact that if you are a resident that's infected and colonized with an MDRO, infected or colonized with an MDRO, your EBP will never go away. It's for the duration of your care at your facility, as long as they're in a skilled nursing or long-term care facility. If they move to assisted living or they move to independent living, then EBP might go away for them if you're not using it in those environments. But it's regardless, it's always going to be there. The two people that you can consider that it might go away is when you're healing all those wounds in your facilities that we all know that you guys are doing great jobs of healing wounds, right? And when the indwelling device goes away. If that's removed, it immediately ends. So when would we use it? During those high contact care activities: dressing, bathing, providing hygiene, changing your linens, toileting, caring for indwelling devices, wound care. And again, for those infected and colonized, it's for the duration of the stay. The PPE required is glove and gown before providing high contact care, and that's in that bundled care. Change PPE before caring for another resident. You might don or doff a face mask or eye protection if there's risk of splash and sprays. There's no room restriction because we want to keep that enhanced, that home-like environment. We want the residents to be able to go and come as they please. Next slide. For transmission-based precautions, I only listed contact precautions as most, but if you remember when we talked about EBP, it said if transmission-based precautions do not apply. So this is in the scenario of somebody's on contact precautions. That would be residents with acute diarrhea, draining wounds, and secretions that you're unable to contain for a limited time during investigating a suspected or confirmed MDRO outbreak, and other infections or conditions where recommended. So when during any entry to a resident's room, you would don PPE. It is a must. EBP is a must, and contact precautions or transmission-based precautions, you're required to wear the PPE. Standard precautions, you kind of decide when you need that based on that risk assessment. So again, PPE that's required, you would go based on the contact precaution or the droplet precaution or the airborne precaution. So gloves, gown on before entry, off before room exit, changing before caring for another resident. You may use face protection, may also be needed for, risk of splash or sprays. With contact precautions and our transmission-based precautions, we usually keep them to a single room if we're available to. Otherwise, they have all of their care in their room except when medically necessary, that we give them dedicated equipment, or we have to disinfect it before we bring it before we use it on anybody else, right? So it increases the amount of work that we're doing. These guidelines, prevent the spread of infections so that we're not spreading, acute diarrhea, draining wounds, all those secretions to everybody else, right? So you can go ahead to the next slide. Some required implementation to implement, we have to post signage and have PPE available. We need to have it immediately available outside the rooms. This serves as a visual reminder for everyone entering or exiting the room to adhere to safety protocols. You need to have access to alcohol-based hand rub or being able to wash your hands outside of the room right before you enter. Generally, it's alcohol-based rub, alcohol-based sanitizer. We want to ensure we have access to that both inside and outside near exit points. Regular hand hygiene is one of the most effective ways to prevent the transmission of infections. We want a waste receptacle near an exit. We also need to have that because that allows for the immediate disposal of use of PPE, minimizing the risk of contamination to other areas. We want to audit and monitor adherence. We want to maintain these standards to be able, we have to regularly audit and monitor how our staff are practicing them. How are they doing? Have we given, if there's something that happened, did we immediately correct it? Did we re-educate? Did we track compliance to it? We can identify areas for improvement, then take corrective action promptly. This is like we do for anything. We're doing audits and monitoring. The fifth step is providing training and education. It's important and essential to provide training and education for all healthcare workers and personnel. Everyone needs to understand why these precautions are necessary and how to properly implement them. In addition to the changes from if you were implementing them back in 2019, the changes throughout this. Remember, these measures are not just guidelines, they're actions that protect us all from potential health risks associated with infectious disease. In nursing, you can visit HAI Prevention to find contact information for your state health department's HAI programs for more specific standards and implementation guides and assistance. We also have a EBP toolkit that has everything you could possibly need. Our amazing QIAs have worked really hard on the EBP toolkit, and it is an amazing resource. So please feel free to use that. I believe it'll be dropped into the chat next. You can go to the next slide. I'm really proud of this slide. I helped create some of these icons, and I'm really excited. I took this little phone here, and I put some little text messages and the chat bubbles on there. So I'm really excited, especially the auditing tool. This was just a clipboard and a little checklist. So I was really excited about this one. But it kind of goes through, the things that are required for infection prevention and control practice in addition to EBP. These are the kind of the things that we do all the time, but they're also incorporated into EBP as well. Just like, all of our things that are incorporated into, next slide, into infection prevention and control practices. So some key points for residents requiring EBP. Gowns and gloves should be worn during activities that involve high contact and discarded after each interaction. This is mostly during that bundled care activity. So when I say bundled care, it's I'm going in to help Sally someone is the example I always use. Sally someone, and she only needed her hair brushed today. When I first needed her, she already had all of her AM care. But once I got in there and I started brushing her hair, then she had to go to the bathroom, and then she had an accident, and it was a lot of mess. So now I have to take her to the shower. So I'm doing a little bit more. It initially started, I didn't come in with my PPE. I have to go back out. I have to get PPE because I'm going to do a lot more care in a longer length of time. Bundled care is the AM care. All of those ADLs that your CNAs, your nurses, they're all providing in a short amount of time to multiple people. That's where it's looking at. That's what the bundled care, high care activities, and in the evening. In addition to that, it is also in the therapy gym. So in a therapy gym where they're being provided therapy to multiple other people, anybody with invasive devices, wounds, and MDRO or infection colonization, all have to have PPE, gowns, glove use during that care, and then discarded when they're caring for another person, hand hygiene, all those things. So some other key moments of that, key points about it is that, again, EBP is for the duration of the stay, except for those wounds that do heal, and medical devices that are removed. If they're colonized, infected, they'll have it for forever. It's intended for MDROs and does not replace or remove the need for current guidelines on infection prevention control measures, standard precautions, or transmission-based precautions. Next slide. Some more key points about it. EBPs are to be used for care provided in residence room mostly, except for that therapy gym. It's shown to be most useful with high contact resident care activities, including transfers, extended length of care provided. That's where that bundled care wording comes from. Most effective when it's grouped or bundled with resident to staff. I obviously didn't read my next line. Staff to resident high contact care activities, such as part of morning and evening care. Other applicable places to use EBP in community areas such as the spa. I know we called it a spa when I was working in long-term care, the therapy gym, and or any shared bathrooms. Next slide. So, what studies were conducted? EBPs were used on residents with permanent devices in 6 different nursing homes and compared with a similar control group, right? EVP signs were put up in the resident's room, closet, medical record, and at the nurse's station. I'm assuming they must have had paper charts or they must have scanned it into an electronic health record, okay? But other IPC measures like hand hygiene were monitored, and the control group received structured IPC training. IPs at the intervention nursing homes were also invited to an infection tracking conference. So they did these 6 different similar facilities with control groups, and you can go to the next slide. And the study results and EVP's effectiveness, the intervention group saw a 23% drop in all MDROs. That's incredible for a trial period, right? A pilot. Fewer new MRSA, methicillin-resistant Staphylococcus aureus, yeah, I got it, cases than the control group. And they also saw less catheter-associated urinary tract infections, CAUTIs, compared to the control group. These are all things that CMS tracks as quality measures as well. You can go ahead to the next slide. So, what expectations of EBP apply to surveys? So surveyors will use probes to question staff about EBP practices. And I took this directly from the Care Pathways. I believe that's a part of the links that I sent over, and you can drop in the chat. Surveyors will use these probes to determine through interview of your staff if they're aware of which residents require the use of EBP before providing care. Now, surveyors know this because they receive the 25 or the 2 reports when they first enter, plus they get a resident roster, right? So they will be able to see through those 2 reports that are reported through the MDS and Casper reports exactly who has infections, who is on transmission-based precautions, who has medical devices, wounds, any infections, any of those things, and who needs assistance, who all of those things that they already know, they will know. So they're going to question your staff about it. They're going to want you to know who is on EBP precautions, and if they're not, should they be? So is the PPE readily available, accessible, and used by staff and nursing units? They're always going to look for that in your IPC practice, but also they're going to have some special attention to it in regards to EBP. They're going to ask about how they're placing a resident on transmission-based precautions or enhanced precautions is communicated to your staff. Does it get passed down? Is it through morning huddle? Is it through your stand up, stand down? How is that information getting down to every single person that needs to know that information? Are hand hygiene supplies readily available to staff? This is a very detailed interview that they're going to ask a bunch of your staff. They're going to say, how do you get hand washing supplies? How do you get PPE if it's out and you don't have it in your area? It doesn't have to be out for them to ask the question, right? They're going to want to know that your staff know who's responsible for restocking or replacing. And what happens if that person's not restocking, not replacing, or out of the office and doesn't do it? Do you have access to that? So pretty important that your staff understand that. They need to know who's on all precautions. They should anyways, because there should be a sign on the door. They should know exactly what to do. But there are other options as well. Let's say someone goes to the doctor today and she didn't have a catheter when she left, but she comes back. How is that determined of whether she's put on EBP? One thing that we have is in the EVP toolkit, we have a EVP decision-making tree, which anybody can go through, answer all the questions, and receive a result on whether a person should be recommended for EVP, enhanced barrier precautions. Any housekeeper, any maintenance guy, you can read through those questions and you see this catheter and you're like, oh, I think Sally someone should be put on EVP. You can go to the nurse and say, hey, I think Sally someone should be put on EVP because they have a new catheter. And I would love to hear that from anybody, okay? I'm not gonna lie, I would love to hear that. So that's what they're going to be expecting of you. What, you can go to the next slide. In addition to all of the things that we have in our EVP toolkit, we also have these resources linked on this PDF and some guidance about it, facts about the EVPs in nursing homes, the total implementation of EVP through the CDC, what was sent out through that QSO memo, and the letter to nursing home residents. This is also all in our EVP toolkit. So you can just go to the toolkit and it's all in a beautiful document. Any IPC resources, of course, you always have Superior Health's website in our resource library. There's tons of information, tons of education that's available. And you can use that information and you can educate. Now you have the PDF of this PowerPoint presentation. And so you can also take this and you can educate your staff. If you're interested in having a script or whatever, just reach out to us at the emails, the roundtable at Superior Health or superiorhealthqa.org. And anyone will be glad to reach out to me and I can get you the script. Okay. Next slide. Enhanced Barrier Precautions Toolkit, I just talked about that. I'd love to show you that in addition to, would you be able to can you click the link of the decision-making tree, Jessica, and we can show that? It's a valuable resource for nursing homes to maintain a safe and healthy environment for all. Otherwise, I can share it too if you want me to. I just want to show you the enhanced, this decision-making tree. So I worked with our amazing communications department to create this. And I literally wrote this out on a piece of paper of like what I really wanted, and I didn't know how to do it. And so they helped me develop this tool that is just, I want you to be able to have at a glance an easy way to decide whether somebody needs it. So you start at question 1, and does the resident have an MDRO? It's either yes or no. You might not know that they have an MDRO. Remember, we went back and we said 50% of residents now have an MDRO, and 53 to, or maybe it was 51 to 73% get it from having a nursing home admission. So you might not know that, but if you do, you can answer that question. So it's a yes. If it's yes, are contact precautions necessary? Are they in that point? And I forgot to mention this, is like, what would happen if somebody was on enhanced barrier precautions and they developed diarrhea or secretions that could not be contained? So then they would transfer over into, and I'm using my hands, transfer over into transmission-based precautions, contact precautions for that. And once that diarrhea or secretions or whatever it is resolved and they're doing better, they would then go back to the enhanced barrier precautions because it really doesn't apply at that point. So if contact precautions are necessary, you answer yes or no, right? And then it tells you if it's yes, use transmission-based precautions. If it's no, now it's going to ask you another question. Does the resident have acute diarrhea? Because we didn't want to miss those things. Those are real important things, right? So then you would answer yes or no. And if you said yes, you're going to use transmission-based precautions. If you said no, you're going to use enhanced barrier precautions. And then you go up to the next question, question 2. Does the resident have a wound regardless of an MDRO status? Yes or no? And if you answer yes, then is the wound chronic? And it talks about pressure injuries, diabetic venous ulcers. In addition, they did come back out and talk about the frequently asked questions were about surgical wounds. Surgical wounds do not require EVP. Initially it was anything that required basically more than a Band-Aid. A dressing treatment, essentially something that you're coating on the MDS, kind of is the way I looked at it. But they changed that to surgical wounds don't apply. They want it to be more chronic pressure injuries, diabetic venous ulcers, things that are much more at risk. Yes or no? Are there excess excretions that can't be contained? Okay, yes. Let's say. Then you're going to use transmission-based precautions. No, then you're going to use enhanced barrier precautions. Then you're going to go on to question 3. And if you answered no to whether they had a wound, it immediately tells you go to the next column. So does the resident have an indwelling medical device regardless of MDRO status? Yes. Okay, you're going to use EVP? No, EVP does not apply. This is why I say it's easy for anybody to be able to pick this up. I suggest you can laminate this, you can print this out, laminate it, you can stuff it in the same place that you have your signs, your enhanced barrier precaution signs, your contact precaution signs. You can even put it in your PPE kits. If you have those plastic storage bins, you can stuff it in the drawers. That way anybody can pull it out and they can be able to read it. And it also gives you a key of the common words that we were talking about in here, what EVP is, what TBP is, so that anybody that might not have come to this training right here or had me in person that needs to know it and didn't already know it, already has it right at hand. So very pretty lovely tool that we got created for you guys. In addition, do you want to pull up the EVP toolkit? We have about 4 more minutes and then I'll go to questions and answers. I did see your question there in the chat. I'll be happy to get to that question. Here's the Enhanced Barriers Toolkit. Like I said, we had an amazing team that worked on this. It gives you every single possible thing. It talks about the QSO memo that was sent out. It has the frequently asked questions about EVP in nursing homes. The one thing I forgot to mention is EVP is for nursing homes. It's not going to occur in hospitals. It's not going to occur in assisted living necessarily. It's not mandated. Now, could you use them in those environments? Absolutely. But it's been shown to show the most effectiveness when used in nursing homes based on the studies that they did. In addition, it talks about the CMS nursing home Medicare and Medicaid programs, the requirements for long-term care facilities to navigate downwards. It gives you all the instructions. They have just done an amazing job with this. I just love it so much. I would love this if I was a DON still. So, and that is the presentation. It was a little bit quicker than I thought it would be, but I saw that there was a question. What are other facilities doing with housekeeping staff when they are cleaning these rooms? Are they required to wear the PPE for all cleaning or just the bathrooms, etc.? I'm going to ask Jessica because it talks about linen changes and it talks about the bathrooms. So what have you heard?
So if you look at the literature regarding enhanced precautions, the studies were done during those high contact activities, and general routine cleaning for an enhanced barrier precaution room does not require PPE. However, if you are making and stripping the bed linens, then you would need the PPE for that activity.
Yeah, that's what I was saying. Thank God. So, like I said, it's that morning and afternoon care, or the morning and evening care, is in addition to therapy. So I did have some housekeeping people that did attend our in-person. I just did, I didn't just do, a couple of weeks ago, I did 250 people. It was a scheduled 300 IPC annual compliance program. And we did hand hygiene, PPE with compliance, with a competency, and then we did enhanced barrier precautions. I did have the housekeeping people attend because it was important if they were doing those linen changes. If the facility said, you know what, we never have our housekeeping staff do that, that's all of our direct care staff that does that, then they didn't need to attend. So I just included them in that education as well. I see you already answered it, but I just wanted to hear you talk. Again, all of those resources. In addition, if you are interested in education or talking about the sustainability of your vaccination program, you can reach out to us at immunizations@superiorhealthqa.org. Again, our mobile vaccination education and Vivint Health which has the education modules, the interactive education modules. Those will end about October 31st. So if you're interested in having a conversation with us about sustainability, you can feel free to email us at that email address. You can still continue to use them all the way up through October 31st, but we just want to make sure you have that information. In addition, I just want to let you know that this is our last nursing home leadership roundtable. I am super sad about that, but I'm also super thankful to all of you who have continued to come for the entire year that I've been presenting for, but the entire time that they had it last year as well. And I just want to say thank you so much for participating. Thank you so much for giving us your feedback. And I will also want to tell you, say thanks to all of the people that work behind the scenes on this event every 2 weeks. Our communications department, everybody that puts together these tools and resources, all of the QIAs that assist us at Superior Health Quality Alliance to get speakers, to talk to speakers, to make suggestions on stuff that they're hearing in your areas of work and when we're calling you to talk about these topics. It's been a fun time presenting these topics. And as you can see, I'm really passionate about EVP and infection control. So I really hope you got a lot from this. Does anybody else have any questions? You can feel free to unmute or put them in the chat and we'll read them aloud. How are your EVP programs going for implementation? Maybe that's a good question. Are you struggling with anything? What are your struggles? Is there stuff that we can help you with in this situation?
I think while we're waiting for questions, I could chime in. One of the biggest citations we've been seeing through some of our directed plan of correction is signage. When somebody goes on or comes off of EBP and maybe they get COVID, and so then they're on the COVID precautions, but the EBP sign is still up. And then they get over COVID and that COVID sign doesn't come down, and staff are confused about which type of precautions they're to be using, and they don't wear the correct PPE.
Would a nurse who that's a good point. So one thing that I learned when I was going into hotspots for DPOCs way back when I was consultant was to teach the staff to, if they're being asked by a surveyor how to don, how to doff, what they should do, they can literally take them to the signs that you have posted on how to don and doff. I use those posters that the CDC had for donning and doffing throughout COVID-19 and the ones that they had previously. And I said, just read it to them. Make sure that this sign is available. Go find the sign. And then you're ensuring, I'll be right back. Let me get that information for you. And you go grab that and they can read it right there. You're not going to mess it up if it's on that sign and you're reading to it and you can speak towards it. So it is important, but having a good process of how those signs get up, how a person is recognized for needing either transmission-based precautions, enhanced barrier precautions, and any PPE in general or protections, is really important. So you should be examining your policies and procedures to make sure that they align with all of the EBP and the way you don and doff PPE, but in addition that they've been updated. And then make sure, I'm going to put a pitch in here for the EPP team and policies and procedures, is to make sure that it gets transferred to your emergency I'm not going to get it, your EPP plan, and that it's a part of your facility assessment. It's a part of all of those things are intertwined and interconnected. So make sure all of them transfer if you change anything right there too. If you're addressing it, it should be taken to your copy. Do a PIP on those programs. I mean, if you're seeing long before ever a surveyor comes in, you see that Sally someone was on contact precautions and that came off a week ago and that sign is still there. Who's doing that auditing the day that they're removed from precautions? Whose job is that? Is that the person that's stocking the PPE or is it the IPC's processes? Do you see if they have, when you do those DPOCs, do you get to see their policy and procedure? And if it's like, if there's a process, or do you ask, Jessica, if they have a process for that?
We go through a root cause analysis, and we don't necessarily see their procedure, but we talk through things and look at what was the root cause and what we need to help put in place for the plan of correction.
What's a common root cause of that?
Usually no one is in charge of the signage, or they've made someone in charge of the signage, but nobody is communicating with that person.
Oh, so
Um,
communication.
yeah, and then I think another thing is cleaning of shared equipment. If you're taking vitals equipment or lifts and stands out of the EBP rooms and not cleaning them, that's another common citation.
Yep. So the question is, would a nurse who is going in to give an injection to a resident with EBP require to gown up? Do you want me to answer, or do you want to?
Well, so I would say if you are going in to give an injection in an arm on a resident where you can easily get to their arm and you're not putting your clothes up against their clothes, I probably wouldn't gown for that, especially, if you're doing an immunization clinic and you're not even in the patient room. But if it's somebody in bed and you've got to roll them around in their bed and you've got to put your clothes up against their clothes, that's where it's a more risk for the transfer of MDROs from clothes to clothes into other residents. So I think in general, if you can do it without putting your body against theirs, I think you're safe. But if there's any question about how much of your body is going up against how much of their body in the room, or if it's bundled, like if they have to go to the bathroom when you get done giving the injection, or all of a sudden there's another care that they need, you want to be prepared for that next care, or you have to leave the bedside and go gown up.
Yeah, that's what I would say. I know that in the FAQs, they talked about whether or not you'd have to do it during medication administration if you're just going in and providing oral medications and whatnot. If you're going in and giving that injection and then you have to do a tube feeding and you have to do all of these other things, makes sense, right? Like that's it's talking about the length of care and how much contact you're having with that person is one of the biggest things in this. And so it just depends on that resident, honestly. If, like she said, I would 100% agree with that. If you're having to do a ton of different things and then all of a sudden because a lot of times nurses are going to do the little quick skin check. If they have to roll them over and they have to do an injection in the thigh or the butt or in the abdomen, they're doing a skin check at that same time. They're kind of doing a little bit more bundling of that care, right? So that's where it becomes a little bit longer process and a little bit more contact that it would be. And then they're going to have to go to the bathroom. And then they're going to, they're just going to want those things. Now, should we interrupt MedPass? No. It's a good question, though. Really good question. In addition, I want to remind you, there has been a survey. I don't know what happened to my words. Where did they go today? We want you to complete the evaluation, your participation evaluation before you leave. We really do appreciate that. It helps give us information and follow up for if this is ever brought back and done at a different time. We can use that information to provide things that you guys are looking forward to. And again, I just want to thank you. I want to thank Jessica. I want to thank Miss Margaret for assisting. We have a couple of roundtable team members that are not here right now. Miss Mykesha Plesko, Miss Tabitha, and they are not here right now, but we are so grateful for their assistance and just we can't wait to see them again, but we really appreciate everything you guys do for us. And any other questions? Do you guys feel like your enhanced barrier precaution programs are going well in your facility? Do you feel like the staff have a good understanding of it? Will you use the EBP decision-making tool or anything else that might assist you with educating your staff? I'm super sad that this is our last one. Thank you so much. And if we don't have any other questions, then we thank you for coming. This concludes our session, and thank you for attending again. Have a great day, everyone.